first case is the case of a 73-year-old Caucasian gentleman who presented initially in June of 2010 with a primary melanoma of the right preauricular region. His primary melanoma was 8 millimeters in depth and was ulcerated, consistent with a stage 1B melanoma. The patient was notable for having had prior resection of one kidney, causing him to have chronic renal insufficiency. However, other than that, he had normal activities of daily living and was fully independent. In June 2016, the patient presented for routine follow-up. His laboratory values were significant for an elevated LDH and an elevated creatinine, but normal liver function tests. Imaging studies demonstrated the presence of opacities in both the lungs and liver, and MRI for the brain was negative for any metastases. The patient underwent a core needle biopsy of one of the lung lesions, which confirmed the presence of metastatic melanoma. This lesion was referred for metastatic testing for a BRAF mutation and was negative for the presence of a BRAF V600 mutation. So this is a patient who is presenting with recurrent metastatic melanoma with a wild-type BRAF genotype. The patient is in his 70s but has good activity status. In terms of medical comorbidities, it's noted that he has abnormal renal function, but otherwise appears to be very healthy. The other tests that are significant are the fact that he has no symptoms and good performance status, but does have an elevated LDH, which is a known negative prognostic factor in patients with metastatic melanoma. For patients with metastatic melanoma, comorbidities present a significant variable to consider in choosing therapies for patients. In addition, the extent of disease, and particularly the serum LDH, can help guide therapeutic decisions in regard to estimating patients' prognosis and the aggressiveness of disease. Finally, it is standard of care at this point in time to test metastatic melanoma lesions for the presence of a BRAF mutation due to the availability of multiple therapies that are effective in patients with a BRAF mutation, but which are ineffective in patients who have a wild-type BRAF gene, as this patient does. This patient initially presented with a stage 1B melanoma that was 8 millimeters thick and ulcerated. One of the questions about this case is whether the patient should have undergone a sentinel lymph node biopsy. While in general, sentinel lymph node biopsy is recommended for patients with Breslow thickness of 1 millimeter or greater, this patient had a relatively thick primary melanoma at 8 millimeters, and in addition had a high-risk feature present with the presence of ulceration, a known prognostic factor in patients with primary disease. Therefore, it would have been reasonable to consider a sentinel lymph node biopsy for this patient at initial presentation. For patients who have known lymph node involvement but no distant metastatic disease, patients are usually seen for the first 2 to 3 years every 3 to 4 months with restaging studies. However, as this patient did not undergo a sentinel lymph node biopsy and therefore had stage 1 disease, he probably would have been followed every 3 to 6 months, primarily with physical exam, dermatologic exam, and perhaps a chest x-ray. However, in retrospect, perhaps it would have been appropriate for this patient to undergone evaluation of his lymph nodes by a sentinel lymph node biopsy to help guide what his follow-up should have been.